Hello, good morning, good afternoon, and good evening to all the speakers, chairs, and the wonderful audiences in different parts of the world. Welcome to the ACNS webinars. The speaker for the first session of today is an honorable guest from Tunisia, Professor Mahdi Damou. Professor Damou is the head of the Monastir Neurosurgery Department of Tunisia. He is the president of the Tunisian Neurosurgery Society, the president of Tunisian Neurosurgery Clinics, and the president of Maghrebian Federation of Neurosurgical Society. He's an important member of the WFNS Audit Committee. He's also an invited faculty to several conferences and workshops around the world, and we're extremely grateful to him for accepting our invitation to be the first speaker at our webinar. And today he will be talking about minimally invasive treatment for spinal canal stenosis.
Recording in progress.
Today is our very honored guest from China, Professor Zhang Xiaobing. He is the chief physician of the neurosurgical department and the director of stroke center at the Shanghai 10th People Hospital, Chongqing University in China. He's a dual-trained neurosurgeon both in open and endovascular techniques. He has a vast experience in surgical and endovascular treatment of cerebrovascular diseases, especially mechanical thrombectomy for patients with acute ischemic stroke, the endovascular treatment of cerebral occlusive diseases, and the embolization and surgical clipping for intracranial aneurysms. Professor Zhang is a training director for mechanical thrombectomy in Chinese Stroke Association. We're extremely honored to have him today with us to be the speaker of our webinars. And he will be talking about the treatment of symptomatic chronic occlusion of internal carotid artery with endovascular techniques. The chair for the first session of today is our distinguished faculty from UAE, Professor Wasim. Professor Wasim is the head of the Department of Neurosurgery at the Sharqut Medical City, Abu Dhabi. He is a vast experienced neurosurgeon with over 23 years of experience dealing with complex cerebral and spinal pathology. Professor Wasim is a distinguished professor in both academic and clinical settings. He previously served as a consultant and head of the Department of Neurosurgery at the Mediclinic and a consultant neurosurgeon at the Taram Hospital. Professor Wasim received his fellowship in skull-base surgery and vascular neurosurgery and neuroanatomical study at the Keio University in Japan, and then completed a research fellowship at the Barrow Neurosurgical Institute in the USA in 2009, after receiving training at the Foundation A. Rothschild in France. Professor Wasim also granted a prestigious associate professor title in 2018 in the Department of Neurosurgery at the University of Alexandria. We're extremely grateful for him for accepting our invitation to be the chair for Professor Damou. The chair for the second session of today's webinar is an honorable guest from Indonesia, Dr. Hassan. Dr. Hassan is an endovascular neurosurgeon from Siloam Hospital and the Kebun, Jakarta, Indonesia. He completed his endovascular training from Taipei Veterans General Hospital. He's an invited faculty to several national and international conferences around the world, and we are extremely grateful to him for accepting our invitation to chair the second session of today's webinar. On behalf of the Educational Committee of the ACNS and the President, Professor Yoko Kato, I would like to welcome both the speakers and chairs and audiences to this online platform of ACNS webinars. A very warm welcome to our colleagues in China, and we're extremely thankful to Professor Shubin for broadcasting webinar on the WeChat channel. Dr. Raja from India is my co-host today, and with that introduction, I would like to hand over this online podium to our first chair, Professor Wasim.
Very much, Professor Raja and Professor, for this introduction. Today we have Professor Mahdi from Tunisia. So welcome and thank you, Professor Mahdi. Can you start?
Thank you. First of all, I would like to thank all the organizing committee of this webinar, and I am happy to participate to this webinar. I will talk about MIS surgery for minimal invasive surgery for lumbar canal stenosis, and especially for microscopic tubular surgery with a unilateral approach with bilateral decompression. Lumbar canal stenosis is typically a progressive degenerative condition, most common seen in patients over the age of 60 years. It It is caused essentially by degenerative facet joint arthrosis, ligamentum hypertrophy, and also disc bulge, leading to compression of the spinal canal and lateral recess. It is manifested by walking disability and leg pain, and it impacts the quality of life and daily activity. Surgical decompression is effective treatment for symptomatic patient, and actually traditional surgical approach are largely replaced by minimal invasive surgery because it affords maximum cure with minimal trauma. We have two main classifications for lumbar canal stenosis: etiologic classification, and most common cause is degenerative change, degenerative canal stenosis. Anatomic classification, we can see central stenosis, lateral stenosis, foraminal stenosis, and extraforaminal stenosis. These are some MRI of lumbar canal stenosis due to disc herniation, due to ligamentum flavum hypertrophy, to osteoarthritis, facet joint, to spondylolisthesis. Other MRI showing multi-level canal stenosis, lumbar canal stenosis, other also multi-level with spondylolisthesis. Also, at least we have 2 or 3 level of lumbar canal stenosis, multi-level also. Here we have only two level of lumbar canal stenosis, and here we have only 1 level of lumbar canal stenosis. Here, MRI classification grading this stenosis from grade 1 mild to grade 3 severe. And we have for central canal, lateral recess, and foraminal. I'll skip. The symptom, classically, lumbar canal stenosis presents with axial low back pain, radiculopathy, or neurological claudication aggravated by ambulation and lumbar extension. Central stenosis presents generally with neurological claudication, whereas lateral recess and foraminal stenosis present with radiculopathy. And mild lumbar canal stenosis is mostly asymptomatic, whereas severe cases present with motor weakness, gait impairment, and abnormal postural sway. The evaluation is done by plain X-ray, computed tomography, and MRI, showing the stenosis very well, the mensuration. The treatment aim is to reduce symptom and improve functional status. The treatment strategy includes the following. We should start by medical treatment, spinal bracing, physical therapy, transcutaneous electric nerve stimulation, neuromodulation, epidural steroid injection, interspinous spacer, and lastly, we can go to surgical decompression if the previous means fail to alleviate the symptom. The indication for surgery, we have at least 2 main indications: typical neurogenic claudication, severe pain, disability, and pronounced constriction of the lumbar spinal canal are the most important indication, but also the failure of non-surgical treatment before surgery, 3 to 6 months before surgery, is also another indication for surgical treatment. What are the surgical procedures? We have the traditional open surgery, could be decompression without instrumentation or decompression with instrumentation with or without fusion. But actually, we have the minimal invasive surgery, microscopic tubular unilateral approach with bilateral decompression, or endoscopic procedure, monoportal, either monoportal or biportal. What are the disadvantages of the open technique? The open technique have a disadvantage: significant destruction of tissue involved in pathologic process, especially the multifidus muscle is elevated from spinous process and lamina bilaterally, and then retracted widely. The supraspinous and interspinous ligament are resected along with their bony attachment to the spinous process. The paraspinal muscle may be denervated and subsequent atrophy may occur, change that have been correlated with the postoperative failed back syndrome. Stability inflection is also altered with loss of the supra and interspinous ligament complex, and dead space is increased, which may increase local wound complication rate, especially infection. Long skin incision we have with losing of the posterior median furrow, which constitute a cosmetic concern for the patient. That's why we actually the tendency is the MIS minimal invasive surgery. This is MRI classification or grading of atrophy of multifidus from grade 0 to grade 2 severe atrophy. Here some figure of traditional decompression, bilateral decompression without fixation, with fixation, with fixation and fusion on one level, on two level. And I will describe the technique of microscopic tubular unilateral decompression with unilateral approach with bilateral decompression for lumbar spinal stenosis, called also over-the-top decompression. It is a minimally invasive procedure for direct decompression of lumbar spinal stenosis. It affords many advantages, but at least we have two main advantages. It minimizes the muscle dissection and bleeding, and it minimizes the risk of producing iatrogenic instability requiring fusion. I will describe this technique. The instrument required, you have the tube, the Violet MIS instrument, I skip. And this is the position in the OR, the position of the patient, prone position, the position of the surgeon, of the assistant, of the microscope, of the CR. Here we do an 18 to 20 millimeter paramedian horizontal skin incision. The muscle was sequentially dilated, and we placed an 18 to 20 millimeter working channel of the shortest length. The operative microscope, we will bring the operative microscope to the field, and we will identify the lamina edge to start the unilateral decompression. We will start the unilateral decompression. Laminotomy was performed, extending cephalad above the insertion of the ligament flavum on the inferior surface of the superior lamina, and caudally to include a smaller portion of the inferior lamina. Resection of the medial facet complex was performed as it necessary to decompress the lateral recess. This is we start initially for unilateral decompression. And here we start the unilateral decompression. Then after we will do the contralateral. The patient is placed on prone position. We ensure the good level by fluoroscopy, and we do the skin incision 1.5 to 2 centimeter paramedian to the midline. And here we insert the dilator and till the last tube about 20 millimeters of diameter, and the tube is typically angled 10 to 15 degrees medially. The tube will be fixed to the table with an arm, and we will before starting the decompression, we will ensure with fluoroscopy the good position of this tube in the right position, and we will start our decompression by drilling the basal of the spinous process and the inferior edge of the superior lamina, and we extend our drilling to the cranially to the insertion of the ligament flavum. And we can also extend our drilling to the upper margin of the lower lamina, and then we will remove the ligament flavum. We will expose the dura and the nerve root ipsilaterally. Then we will do, after doing this unilateral decompression, we'll do the contralateral decompression. The working channel was then angled medially. The microscope also angled to expose the anterior aspect of the spine process, the basal aspect of the spine process, which was then removed with the drill. This procedure exposes the lateral recess on the contralateral side, where the residual lamina and ligament flavum could be resected using the drill, Kerrison punch, and curettes. Here we will do the contralateral decompression. We will move the table. We will 10 to 20 degree in the contralateral side. Also, we will angulate our tube and angulate our microscope, and we will start the drilling of the ventral aspect of the contralateral lamina, keeping the ligament flavum at the end to protect the dura. And we will continue this drill, this bone decompression, and then we'll remove the ligament flavum and expose the dura and the contralateral root. The contralateral root, and at the end we will verify the complete decompression in a clockwise manner starting at 11 o'clock, and we will do our closure in the unilateral side as described. Here I will show you some MRI of lumbar canal compression before surgery, and here after surgery. In L4, L5 we have a good decompression with unilateral approach. Another image showing preoperative, we have a compression, central compression of the lumbar spine, and with unilateral operation we have a good decompression and expansion of the thecal sac. Which side we will do this approach? Habitually, we will do this approach on the maximum of compression, and there is an article in orthopedic surgery, and the author choose the side according to the maximum of compression, and according also to the spinous process deviation. Is the spinous process deviated, they will do they will approach on the contralateral side of the deviation. If not deviated, they will see if there is the maximum of compression, and they will do the approach on the maximum of the compression. If there is no maximum, if the compression is symmetrical and the surgeon choice, this is the surgeon choice to base it on handness. Here, in the first picture, we have symmetrical compression, and the surgeon choose the left approach. Here, we have the compression from the contralateral side of the spinous process deviation, and here, the decompression in the side of the maximum of compression. Here, another MRI showing the approach we'll do in the contralateral side of spinous process deviation. And the added advantage of the microscopic tubular lumbar canal stenosis are smaller skin incision with complete decompression, less blood loss, short operative time, less complication, especially less infection. We have short hospital stay, fast post-operative recovery, reduction of medical consumption, early return to work, and the last, a patient satisfied patient. Here I will show you one of my patients, an illustrative case, a 68-year female complaining of neurogenic claudication and bilateral radicular pain with a visual analog scale of 7 and ODI high, and MRI showed L4, L5 lumbar stenosis. We do for her, I will show you a short video. We start with the left paramedian incision, 18 millimeter. We do the dilation. And we introduce the different caliber of dilator, and finally the tube of 20 millimeter. And here we ensure the good position of the tube, and we bring the microscope and start our unilateral decompression. After removing the soft tissue, we will drill the lamina, the upper lamina and the base of the spinous process, and we will resect the ligament flavum in the ipsilateral side, and we'll start to see the dura. And we decompress the thecal sac and the nerve root. And then we will rotate the table and we will angulate the tube to do the contralateral decompression, starting in the base of the spinal process and drilling the ventral aspect of the lamina, then contralateral lamina, then removing the ligament flavum. And at the end, we had good decompression and the muscle returned to its place. Postoperatively, the patient improved very well, and we have the preoperative MRI and the postoperative CT scan showing good decompression by unilateral approach. And in conclusion, MIS microscopic tubular unilateral approach with bilateral decompression is clinically feasible and safe to treat the lumbar canal stenosis. And the lateral stenosis, microscopic ULBD could be a primary tool in the spine surgeon's armamentarium because of it afford many surgical advantage, less muscle trauma, minimal postoperative back pain, fast recovery, and high patient satisfaction. And thank you for your attention.
Thank you very much, Professor Mahdi, for this elegant presentation about MIS techniques in lumbar canal stenosis. So my question to you is your algorithm in choosing patients when you do the MIS technique versus doing more open techniques with insertion of screws and cage to treat the patients. What is your strategy of thinking in these patients?
Yes, before I did the classic technique with, but actually I shift more where the MIS technique, and especially for elderly patient, for patient with comorbidity, and also we can do it this decompression with percutaneous insertion of the screw. No problem. We can do the decompression of the, but mainly I do it without screws for elderly and for a patient with comorbidity. And if there is also only one segment, why to do instrumentation and fusion? And I have good result.
So in case of foraminal stenosis, you also do it MIS techniques, or you try to do the indirect?
Yes. We can do it, yes. I do now actually MIS technique for foraminal stenosis, yes.
Stenosis. So we all know that most of those patients are old age with lots of comorbidities. How you?
Not most. I have some patient not old with one segment stenosis, and the result is very good. Without instability, we can do it. No problem.
Yes. For the local with the epidural anesthesia, have you tried to do the?
No, I did it for under general anesthesia. Yes.
So thank you, Professor Mahdi, for this presentation. And any questions from you, Raja? Or?
Yeah, Ben has raised his hand. Ben, you can ask.
Ben?
Yes, and thank you, Professor Tamo. It's a really nice presentation and really good illustration that how the surgery is performed. So I have some questions. The first question is about the when you use this tubular retractor, and then you will have to, for minimally invasive, it's correct that it's very important that you achieve the correct level and the correct tilting. So how do you any tips for a young neurosurgeon in particular confirming the level, and also during the surgery when you tilt and the tubular retractor? So how do you decide how much you need to tilt? Because sometimes if you tilt too much, you may drill too much of the bone. And my second question is about there is a trend that is increasing use of the endoscope. So how do you compare the endoscopic or microscopic surgery in general for the spinal surgery, for minimal invasive technique? Thank you so much.
Yes, for the first question for the young neurosurgeon, I tell them to assist in different webinar, different courses, and there is a learning curve. And if they start, they should keep the ligament flavum at the end. They should do firstly the drilling and they to not have complication. And the second question is how to choose between microscope and endoscope.
Yes.
Yes, we can use also endoscope for this technique, but there is a learning curve also for endoscope, and the results are the same. I think the result between endoscope and microscope, the result are the same. No problem. And there is also a learning curve for endoscope, and we can do this technique by endoscope also.
Thank you so much.
Right. If I may ask one question to Prof. Dharmal, first of all, let me congratulate you for this wonderful lecture and showing us beautiful operative techniques. As you said, there is a learning curve for endoscopy. I went through that learning curve and I'm still learning.
Yes.
What are your tips with regard to decompressing the ipsilateral foramen, because the spinous process is here, you have docked it here, so you won't be seeing the ipsilateral foramen unless you take the facet. So like do you
Yes.
have any tips, like do you use some
The
foraminal
landmark,
punch,
yes. Yes.
foraminal punch or something like that?
For to go to the base of the spinal
Ipsilateral.
process, we can turn the tube, no problem. We can turn to the ipsilateral foramen and do the decompression.
Yeah, but how much of facet do you recommend to remove?
The facet, if there is a compression, at least the third part of the facet.
One.
Yes, there is a good, yes.
Right. Thank you very much. So we can hear our concluding remarks from the Honorable Chair, Professor Wasim Aziz.
Thank you.
So thank you very much, Professor Mahdi, for this nice and elegant presentation. We are happy to hear this technique from you, and your surgical skills and tips for treatment is very important to know. Thank you very much, Professor, and thank you, Rajan. Thank you, Professor Ben, for this nice talk.
Thank you.
Nice presentation. Thank you.
Thank you. Thank you very much.
Thank you.
So we'll move on to the second session. Thank you very much, both the speaker and chair. Dr. Ben?
So this concludes our first section. So maybe I hand over to our second chair, Dr. Hassan, to introduce our second speakers.
Thank you. Good afternoon, everybody. So I'm based in Indonesia, so I say just good afternoon to everybody. Without further ado, I think I will let Professor Chang from Shanghai to present his work about intracranial artery occlusion and treated by endovascularly. Please, Professor Chang.
Fine, thank you very much. So
Yeah.
today I want to share my experience in the endovascular treatment for patients with chronic occlusion of ICA, and we know the chronic occlusion of ICA, COICA, is usually defined as complete occlusion of internal carotid artery that lasts more than 4 weeks. And when compared with the acute occlusion, the chronic occlusion of ICA is often clinically overlooked. As a matter of fact, in patients with symptomatic chronic occlusion ICA, the annual stroke risk is at least 5% in patients refractory to medicine. And due to the long-term hypoperfusion of cerebral hemisphere, the cognitive impairment and the refractory hypertension are very prevalent. Although chronic occlusion of ICA is associated with significant risk of ischemic stroke and other hazards. The revascularization technique are neither well established nor widespread. As far as open surgery is concerned, we know ECIC bypass have long been performed for patients with symptomatic CICA. However, it failed to show benefit by the RCT study, possibly because of relatively high peri-procedural complications. Here, I mean the course study. And the neurointerventional technique have developed rapidly in the past 30 years. However, up to now, today, endovascular recanalization for CICA is still a great technical challenge. Why? I think there are three major differences we compared with the acute occlusion. First, for the chronic occlusion of ICA, the occlusion segment is relatively long, a long segment occlusion. Second, the lumen may collapse, become fibrotic, or even calcified. Third, with the duration of occlusion prolongs, the carotid stump may become blunt, I means transformed from a tapered stump to blunt stump or even disappear. So I think the endovascular recanalization for CICA needs technical innovation. And in the mechanical thrombectomy for patients with acute ischemic stroke due to tendon lesion, we found a full coaxial system containing 6 French short catheter, 6 French intermediate catheter, and 5 French vertebral catheter and thermal sleeve guidewire. Had at least 3 advantages. First, the carotid stump could be easily penetrated. Second, the intermediate catheter could be placed rapidly to the cavernous segment. Third, during the mechanical thrombectomy, the short catheter could completely block the antegrade blood flow, which minimizes the distal embolization. So we attempted to use this full coaxial system to recanalize the chronic occlusion of internal carotid artery, and we achieved success. With the increasing case, we continue optimize the procedure and gradually developed a new technique and named it the COCO technique. And in 2023, yes, we published our COCO technique in JNIS. And briefly, the COCO technique includes 7 steps. First step is the penetration of carotid stump. Second, the establishment of treatment path. Third, probing of the distal petit lumen. And step 4, exchange with long micro guidewire. Step 5, angioplasty with balloon. Step 6, the reconstruction of the intracranial ICA, and the last step is the reconstruction of extracranial ICA. Actually, among the 7 steps, the first 3 steps are most critical. And the first step is how to penetrate the stump. As this is a taper stump, blunt stump, and low stump. For the taper case with taper stump, we always use a stiff get well to penetrate. It's not very difficult, actually, not difficult, very easy. However, for case with blunt stump, you may think it's very difficult. And in case with low stump, you may think it's impossible. Okay, how to penetrate a blunt stump? I always use a 5 French with a braille cutter to make a breakthrough. Here you can see the breakthrough happened at the anterior wall of ICA. It's very interesting. This is a similar case. This is the similar stance. This is the similar. This case is not very difficult. So we stop our penetration from here. Okay, let me say what happened. It's okay. It's very difficult. So I changed it to the hypothetical anterior wall and succeed in penetration. It's very interesting. So I think we succeed in penetration at the hypothetical anterior wall. Okay, just like this one. This is not a true stump, but an ulcerated plaque. So for case without stump, I always target the hypothetical anterior wall of ICA, and actually, in most cases, we can succeed in penetration. It's not difficult. So you can see here, they get well, goes very smoothly. So how to penetrate the stump? Please keep this passage in mind. We know the majority of chronic occlusion evolve from stenosis. And to the arranging of the ICA, the stenosis always progress from posterior to anterior. Therefore, the anterior wall of ICA is often the final point of occlusion and serves the precise breakthrough target during recanalization, just like this one. Okay, from posterior to anterior. So the anterior wall is the last occlusion point, and our penetration should target the anterior wall. Okay. The second step is how to establish a treatment path. In my experience, I always use a 4 coaxial system, and both intermediate catheter and short catheter was well placed as deep as possible. Usually, the intermediate catheter was placed at the curved segment, and the short catheter was also placed very deep. As the intermediate catheter is placed very high, the remaining occlusion is very short, so making the probing of the distal patent lumen easier. Also, as short catheter blocks the antegrade blood flow, the risk of distal embolization is greatly minimized. And this step 3 is also very critical. I always compare the step 3 is the final kick before before scoring a goal. So the most critical question is how to make sure the macro gateway is in the distal patent lumen. How to make sure? My experience is just rotate the macro gateway and carefully observe the oscillation of the macro gateway. If the oscillation amplitude correspond to the blood vessel, just means they correspond to the diameter of the blood vessel. It means it is in the true lumen. It's very critical. So we can see this case. The macro gateway tip, the oscillation, correspond to MCA, the diameter of MCA. So I'm sure it is in the true lumen. So we can advance the macro catheter. And this is the Hansen classification of cell ICA. This classification is specially based on the difficulty level of endovascular treatment. Among the 4 types, type A, type B are relatively easy, but type C, type D is very difficult, or you may think is impossible to recanalize with endovascular technique. Here, I will show you how I recanalize these cases. Case 1 is a 68-year-old man who presented with recurrent left-sided weakness. This MRI and the MRP showed a hypoperfusion of right hemisphere. And the DSA revealed a taper stump, and the intracranial segment was retrogradely obfuscated while ophthalmic artery from ICA anastomosis. Okay, this video will show how this coaxial system works. This is the stiff gateway, the vertebral catheter, the intermediate catheter, and this is this system. So each member of this is a long shot catheter. So you can see members of this coaxial system cooperated together, and after the penetration, we could advance the intermediate catheter very deep, and the intermediate catheter was advanced to the cavernous segment. Here you can see the intermediate catheter demonstrated perfect trackability. As the intermediate catheter was placed at the cavernous segment, so the microvalve and the microcatheter was very easily advanced to the distal patent lumen. So after confirmation with the roadmap, exchange with the long microgateway were performed. After that, a balloon angioplasty was performed from distal to proximal. And during the angioplasty, ballonplasty, we would aspirate with a syringe to clear out any possible debris. Okay. just step by step from distal to proximal. This is deployment of a protective device. This is the final result. You can see successful recanalization was achieved without any distal embolization. The patient's post-operative recovery is uneventful. This case A. Next case is type C. This case we can find there is no stump, case without stump, and the intracranial segment was obfuscated by a retrograde flow from ophthalmic artery. Usually, the case without stump, the success rate for endovascular treatment is less than 50%, while the complication rate is as high as 46%. So, hybrid surgery is always usually recommended. But we can utilizing this COCO system to establish a treatment path. Okay, after establishment of the treatment path, we succeed probing the distal palatine lumen. This is the balloon angioplasty. This is a stent reconstruction for the intracranial segment. This is final result. Actually, for the usually, I always choose the self-expandable stent for a reconstruction of intracranial segment. Although some doctor would to report the employment of balloon expandable stent. I like self-expandable stent. Okay, the type C, without stump, we can succeed recanalization. Even type D, I do many cases is type D. This case we can see there is a taper stump, but the intracranial segment is invisible. That means low retrograde flow from ICA to reconstitute the intracranial segment, and the collateral flow to the right hemisphere is limited. This patient is 57 years old, and his chief complaint is speech impediment and dizziness. And his cell ICA was diagnosed with CTA 4 years ago. For this case, at the beginning, I am not so confident, but with the COCO technique, you can see the penetration with a stiff guide wire is not difficult. We use the stiff guide wire, you can see here, yeah, very easily penetrate the stump and establish the treatment path. This is the intermediate catheter, the long short catheter. Okay, at the beginning, it's very lucky. However, the roadmap with through a microcatheter injection showing a short a CCF. At this moment, my initial thought was just give up. And however, I'm somewhat reluctant to give up. So I try again. As a result, the ophthalmic artery was obfuscated, which means the microcatheter returned to the true lumen. So proceeded to probe the distal segment. And this case, they primary occlusion happened and the intracranial segment. So single microcat wire is too soft to make a breakthrough. So I choose the stiffer microcat wire and succeed. Here, please observe the oscillation of the macro tip to the diameter of blood vessel. So I'm sure the microcat wire was in the true lumen. This is the confirmation with root map, microcat root map. Thereafter, balloon angioplasty and stent reconstruction was sequentially performed. And for the extracranial segment, I prefer to use a wall stand to reconstruct the lesion. This is the final result. The recanalization was achieved, but the CCF persisted. At that moment, at that time, because the low retrograde venous reflux to the cardiac vein, to the ophthalmic vein, so I left it untreated. However, 1 month later, this patient reported a sensation of distending pain around his left orbit. So follow-up DSA was performed and showing the retrograde draining to the ophthalmic vein, superior ophthalmic vein and inferior ophthalmic vein. And the fettular face is very, very obvious. So balloon-assisted embolization was performed. And this is the final result. This patient symptoms due to the hypoperfusion disappeared completely, and his life quality was greatly improved. Case 4, also a very interesting case. This is a 46-year-old man presenting with right-sided weakness. He was diagnosed as left carotid artery occlusion 5 weeks ago, and he complained of dysuria 2 days before admission. This MRI showing the watershed infarction. MRP showed the hypoperfusion in the left hemisphere, this CTA. So, and the high resolution MRI showed occlusive dissection, and which extended from extracranial to intracranial segment. So it's a very long dissection and long occlusion. And left ICA angiography showed a tapered stump, which is characteristic of dissecting lesion. And there the intracranial segment was not obfuscated. And the collateral circulation from right ICA is limited. Okay. For this case, I think it's very difficult. I don't think the successful chance is high, but I tried with the Koch technique. This is the establishment. Fortunately, we established the treatment path and advanced the microcatheter to the distal true lumen. This is MCA, M1, MCA. And this case is a dissecting lesion. So I use a balloon and inflated it. And by utilizing the balloon anchoring effect, I directly advanced the intermediate catheter to the intracranial segment. At this time, I opened the stopcoccus and observed brachial backflow. So it's become very easy as it was caused by dissection. So I directly reconstruct the vessel from distal to proximal. And for the intracranial segment, I use the EP stent. And for extracranial segment, I use the wall stent. So it took me just less than 1 hour finish the treatment. This is the final result. Total recanalization was achieved without distal embolization. Okay. My last case is case 5. The age 72 years old man was diagnosed total occlusion left ICA since 2018. And these are the CTA he wanted every year. Okay, MRP showed hemodynamic compromise of his left hemisphere. And the left ICA angiography showed a blunt stump, and the intracranial segment was reconstituted by the retrograde flow from ophthalmic artery. For this case has a very long time occlusion, about 4 to 5 years. So the penetration of stump is difficult. However, after several attempts, I succeeded in penetration. Another difficulty is during the establishment of the treatment path, we observe there is a loop, which confused me a moment. I just referred to the right ICA angiography. The right side ICA also have a loop. So I make sure our guide wire and the catheter was still in the true lumen. So I successfully established the treatment path and achieved they did the probing of distal to lumen. This is the construction with EP stent. This is the final result. The recanalization was achieved. And 1 year follow-up, it is very, very, very nice. So from 2019 to 2025, a total of 142 cases were treated with Coco technique. The overall success rate was 86%, and the intraprocedural complication occurred in more than 20% of cases. Among them, CSF 13, dissection 9, and perforation 8. Distal embolization only 1. Post-procedure hemorrhage stroke occurred in 5 patients, resulting in 2 deaths and 1 severe disability. So my conclusion is Coco technique can significantly increase the success rate of revascularization of full ICA and minimize the risk of distal embolization. However, intraprocedural complication rate is still high. Okay, thank you. Thank you. Professor Hassan?
Yeah, thank you very much, Prof. Zhang, for very inspiring presentation. If you're asking me, will I do it? Then shortly I will answer, I'm afraid. because you puncture a blunt segment. That is very worry for me. Then my first question is, what happened if accidentally you puncture internal carotid artery? What is in your experience?
Yeah. Yes, this is a very nice question, a very critical question. The question is how to escape the puncture of the intracranial vessel. Yeah, it's very, very critical. So, in my PPT, I showed when they advance the micro guide wire, we just rotate the micro guide wire and observe the oscillation. If
Movement.
they, If the oscillation amplitude correspond to the diameter of the vessel, just ICA or MCA, I'm sure the micro guide wire was in a true lumen. If the oscillation amplitude is very large, it means it have punctured the vessel. So we can't advance the micro catheter up. It's very critical. If the oscillation amplitude is small and not light, it cannot move smoothly. It means it was in a dissection. So it's a very critical question. Yeah.
Okay.
If
Prof.
I may
Sang.
ask one question.
Sorry, can I read the question
Yes.
in the tab? So this is a question
Chat
from
box. Yes.
Julius Hermanto. Professor Chang, in your technique, how often do you encounter perioperative complication? Is this technique suitable for acute stroke with intracranial artery disease? ICAT, intracranial artery disease.
Beg your pardon. Can you repeat the question? Shortly.
Okay. Yeah. Or maybe you can read in the question and answer tab. There is a question and answer tab below. You can click and you can read. How often do you encounter perioperative complication? Is this technique suitable for acute stroke with ICAT? For acute stroke with intracranial artery disease, or maybe some atherosclerotic change.
Sure. I think I know when we perform the recanalization for the chronic occlusion ICA, the periprocedial complication is still very high. As high as in my case, about more than 20%. The most complication is related to the manipulation of the microguide wire, So in my cases, the most frequent complication is the CCF. The second is the dissection, and the third is the perforation of vessel. And I think the technique, the technique just evolved from the technique I used to treat the acute occlusion. ICA occlusion, especially for the occlusion for the ICA occlusion, it's very, very easy. Why I do this technique? Because in my treatment with the case, the acute ischemic case, due to the tandemlation,
Condemnation, yeah.
Yeah.
Occlusion in the neck and in the MCA.
Yes. MCA, no. Yeah.
Yeah, but tandem means, yeah.
Yeah. I know. ICA plus MCA.
Yeah.
Yeah, sure.
Ask one question.
Yeah, sure.
Can I ask?
Yeah.
And do you have intravascular ultrasound? Would it help in this procedure?
And I don't do the intravascular ultrasound. No.
Now, would it be helpful in this condition if we use? Because you can see the lumen
Yeah.
inside the
Maybe I think
intraluminal.
yes. Maybe I think it will be helpful. However, I just observe the oscillation amplitude of micro guide wire. I think it's very different. It's very important when I do the chronic occlusion recanalization. Where it's probably even include the MCA chronic occlusion of MCA. I always use the observe the oscillation amplitude of the micro guide wire. It's very important. So I'm very confident with this technique.
Okay.
So, can I ask a question?
Yeah, sure.
Yes, of
Two
course.
questions. First, how
Oh.
important? Yes, Professor. Nice to meet you. So, how important in the preoperative imaging in your decision making? What I mean is, any cases you say I cannot do that for this case, or all cases of chronic occlusion is suitable for
Okay.
this? This is my first.
Yeah.
This is my first.
Yeah. So for every case, I plan to perform recanalization. I would perform the MRI, MRI, and sometimes the high resolution MRI, and the CTP or MRP. And DSA examination is that's all.
So my second question is that isn't it too late to depend on the microwire oscillation? Because if you find not the correct oscillation, it is outside already the lumen.
Okay. Yeah, very nice question. Why? Why I think the oscillation amplitude of microguide is so important? During the recanalization, during the probing of distal segment, if the microguide wire penetrates the vessel and related to a perforation, it's not dangerous. We just pull back the microguide wire. There is always no hemorrhage, low SH, or just not very severe SH is safe. However, if the microguide wire have perforate the vessel and we advance the microcatheter,
This is
it's
the dangerous part.
dangerous. Yes, the SH is very severe. So I think we observe the oscillation amplitude of microguide wire is very important. It's very critical. Do you know?
Yes, I understand your concept now.
Sure.
So thank you.
Yeah, thank you.
Okay, that is very interesting, and I think many audience still have many questions. But before I continue, I want to ask you: is there any pre-op preparation like anticoagulation for the patient, or what you do? Because this is also high risk for rupture.
Yeah, actually, the pre-operation medicine is similar to the CAS or CAS, double dual antiplatelet. Yeah.
Well, antiplatelet, yeah.
Same, yeah, same.
Okay, then when you say the acute occlusion easier,
Yeah.
but in some cases, in the acute phase, we afraid of hyperperfusion syndrome.
Yeah, it's a very
how you manage the time? Well, when to do? What is the time window to do the recanalization after occlusion?
Yes, actually, some doctors think the earlier the better.
Yeah.
For the COSA. Actually, I think the earlier is not the better. I have reported there are 5 post-operative hemorrhage, cerebral hemorrhage. Among them, 2 deaths, 1 severe disability. All 3 cases are performed after the occlusion, 4 weeks or 5 weeks after acute occlusion. And they left the 2 cases. They have history of occlusion of 1 year and 2 years. Although there is a hemorrhage, but very tiny, with small hemorrhage. So I would like to treat the cell ICA for a long time because I think the hemodynamic is more stable.
Okay.
Yes. So
Okay.
up to now, what I'm most concerned is hypoperfusion.
Okay.
Yes.
So then, when you do usually after occlusion, like 4 months or 6 months, or what you do recanalization when?
Yeah, I don't. Oh, I will tell you. The last case, I do a case have a occlusion history of 10 years.
That's it. Okay.
Yeah, I still can succeed in such cases. 10 years, even no problem.
Okay. Yeah, thank you. It is a nice
Thank you.
presentation.
And there are 2 questions from me. And thank you so much, Professor Zhang. Great sharing about this very special technique for the occlusion. But my first question is about during the procedure. So how do you prevent the emboli, and especially at when you penetrate the stomach? So because it is the time that you don't have there is the time that you cannot put any embolic protection device, and so do you give antiplatelet at that moment, or give anticoagulant at that moment? So what is the precaution that you prevent the embolization? My second question is about, you mentioned there's some case of the dissections. And how do you know that you are in the dissection, and how can you move back to the correct Newman in that case?
Okay, very nice question. Yes, when we perform the endovascular treatment for cell ICA, the most worried problem is the embolization, distal embolization. Actually, when we use the Koch technique, before our long shot catheter was placed very high, which completely block the antegrade blood flow. So there is low risk of distal embolization. And you say, I have only one case, only one case. So this risk of the distal embolization is very, very seldom, I think, because we use the short catheter to block the antegrade blood flow. So don't worry. Say the question is how to make sure our guide wire or catheter was in the true lumen or not in the dissection. I think, carefully observe the movement of the guide wire. If the guide wire goes smoothly, it was in the true lumen. If it goes unsmoothly, so I think it was in the dissection. Just observe the movement of the guide wire. I think it's very critical. So for the intracranial segment, I saw oscillation amplitude is critical. For the extract sleeve guide wire, Okay.
Thank you so much.
Yeah, so Prof. Chan just share to us, we can say like a new treatment, because most of us, if we see there is an occlusion, usually we give up, or we try to do bypass, either high flow or low flow or double bypass. But today, Prof. Chang just inspired us that there is still a possibility, even as he said, after 10 years of occlusion, there is still a possibility to reopen the occlusion of the carotid artery. Thank you, Prof. Chang, for the new inspiration.
Yes, thank you,
And
Professor.
now I conclude the session and I give back to Ben.
So thank you all the speakers today and the chairs today. It's indeed a very wonderful and we all learn so much from these two very excellent webinars. So on behalf of the Education Committee of the ACNS and Professor Yoko Kato, I would like to thank both the speakers of today, Professor Mehdi Damo and also Professor Zheng Xiaobing, as well as the chairs, Professor Wasim and also Dr. Hassan, for the time and the support for the ACNS webinar. A special thanks to Professor Shibin for broadcasting this webinar on the WeChat channel, and special thanks to my co-host, Roger, for joining me today. Until we all meet online tomorrow, is a bye-bye from all of us, and thank you so much for joining today's webinar.